This is a very good explanation on the menstrual cycle, and you see on this graph here when the estrogen is highest. This is usually when I get my migraines, a few days before, and then here the usual thing, here in between I got my migraines. And why? Because high estrogen increases histamine in the reproductive organs. More histamine results in more estrogen, and so on.
That hormone imbalances, things like estrogen dominance and low progesterone and low testosterone, low DHEA, and even high estrogen could be additional challenges filling up your histamine and MCAS bucket. In today's video, I'm going to explain to you how sex hormones are connected to histamine intolerance and MCAS. And if you stay with me all the way to the end, I'm going to share with you 5 lifestyle tips that you can start implementing today that will help your hormones, which in turn will help your histamine intolerance and MCAS symptoms. If you're just joining me, I'm Dr. Hagmeyer. I'm the clinic director here at drhagmeyer.com, where we help patients who struggle with chronic health problems find answers and solutions to some of the most challenging health problems. Dealing with histamine intolerance and MCAS can be incredibly challenging, and this is due to the fact that there are really just many aspects of your health that need to be considered above and beyond a high histamine diet. Yet these are areas that are often overlooked, and sadly most doctors tend to think that living on histamine blockers is really the answer and the solution to histamine intolerance and MCAS. And I'm here to tell you today that this is not a solution. You cannot live on these medications long term. They will have serious consequences on your health. You need to focus on the big picture.
Myofascial pain. It may persist for months and even years. Even after it subsides, it may recur in the same muscle groups with uncanny persistence with ordinary life stress. Myofascial pain, of course, is a common condition found in many types of injuries, and also notably triggered by life stress. Common tension headaches are due to stress-related myofascial spasms in head and neck muscles. In fact, probably the most common cause for chronic headaches, neck and low back pain is myofascial pain.
I like to use the bucket analogy. Whenever I talk about histamine intolerance and MCAS, there are actual root causes behind this, right? And so in this video series, we're talking about many different parts, or things for that matter, that fill up your bucket, your histamine and MCAS bucket, causing it to overflow. And of course, the more you struggle with the symptoms of histamine intolerance and MCAS, the more you're going to miss out on life. And so your bucket is filled up not because there is a shortage of Zyrtec or Zantac or Benadryl or Claritin in your blood, and taking H1 and H2 blockers does not stop why you have excess histamines in your body in the first place. Some people with MCAS and histamine intolerance have a bucket that is just filled with all kinds of problems. But if you're serious about getting your life back and feeling good again and being in control of your life, your focus really needs to be on understanding what's filling up your bucket.
The pathophysiology of stress. The concept that prolonged or excessive exposure to stress could contribute to the development of specific diseases was formulated by Selye in 1936. His original studies are mentioned in Chapter 2 and have led to the conclusion that exposure of an animal or a person to a variety of stressors would result in a complex neuroendocrine response primarily involving the hormones of the pituitary gland and adrenal cortex. These responses were critical to the survival of the organism when subjected to an acute stress. But exposure to prolonged or cumulative stress could result in damage to the organism. Much of this damage was due to prolonged exposure to adrenal cortical hormones, especially cortisol. So, celiac rats subjected to prolonged, inescapable stress were found to develop erosion of the stomach lining, atherosclerosis, and atrophy of the adrenals. Celiac's findings have been validated by more than a half-century of research and support the role of pituitary adrenal cortical activity in stress modulation and in the development of specific diseases. We have discussed the role of cortisol and other so-called glucocorticoids in modulating the acute role of the brain neurotransmitter norepinephrine in stress. Cortisol actually inhibits the acute effects of stress-based arousal by norepinephrine on the limbic system, especially the amygdala. Cortisol also regulates the hypothalamic pituitary adrenal axis HPA in the ongoing response to stress. It operates via a negative feedback loop that inhibits the hypothalamus and pituitary gland. Elevation of serum cortisol therefore inhibits the release of ACTH, an example of many of the feedback servo systems in the body that promote homeostasis. The complex effects of gluco and mineralocorticoids, those that control sodium, potassium, and water, also serve to manage the body's secondary line of defense to stress. These effects include retaining sodium in the body and mobilizing glucose from glycogen in the liver. They increase blood volume and provide increased sources of energy production, both necessary for managing chronic stress. All of these responses prepare the organism to deal with prolonged stress at the expense of long-term health. The resulting immune, metabolic, and neuronal responses are important in the organism's early defenses to abnormal stressors, but if prolonged may lead to specific organ damage. The diseases of stress that result from prolonged stress adaptation reflect the well-known systematic side effects of prolonged therapeutic glucocorticoid cortisol administration. These diseases include diabetes, atherosclerosis, hypertension, peptic ulcer disease, obesity, osteoporosis, and cognitive emotional impairment, all attributable to the effects described previously. In addition, excess exposure to cortisol in animals has been found to selectively damage neurons, primarily in the hippocampus, the brain center for declarative memory. All of these diseases appear to accurately reflect the findings in Celiac chronically stressed rats. Clearly, chronic and prolonged exposure to unremitting life stress is associated with a cluster of vascular, hormonal, immunological, neuronal, and degenerative diseases that are largely attributable to exposure to abnormal amounts of glucocorticoids. Stress versus trauma. Prolonged stress and trauma, although they are basically part of the same continuum, differ in a number of ways. Stress may be defined in one sense as any negative stimulus that produces persistent activation of the sympathetic nervous system and related HPA pathways. Trauma may be viewed in this light as an extreme form of stress, one that has assumed life-threatening proportions. Trauma also is usually a sentinel event or events of great threat and magnitude, producing a maximal arousal fight-flight response. Also, the neurophysiological effects of trauma will often not occur unless there is an element of lack of control or helplessness associated with the stress. When relative helplessness is present, an experience of terror or horror may accompany the traumatic event, an emotional state that is very suggestive of elements of the freeze immobility response. Once again, the combination of a life threat associated with helplessness is the prerequisite for trauma to occur. In our previous discussion of the meaning of the freeze response, we noted that the physiology of freezing involves intense vagal parasympathetic tone. If a high-energy sympathetic fight-flight response has preceded the freeze, the autonomic climate of the freeze may be a rapid and exaggerated sympathetic parasympathetic cycling, much like the analogy of simultaneous pressure on the accelerator and brake pedals of a car. However, the freeze response ultimately assumes a state of predominantly dorsal vagal dominance. The freeze represents a temporary adaptation to acute stress that is not physiological sustainable, and one that is certainly not associated with continued arousal associated with adrenaline and elevation of serum cortisol. As we have noted, the freeze response very likely is associated with the perceptual state that we call dissociation, an event that is a powerful predictor of the subsequent development of PTSD in individuals subjected to a traumatic experience. Traumatic stress and the development of PTSD are not inevitable with exposure to stress or trauma, however life-threatening. These events very likely depend on the event of the freeze immobility response occurring in state of helplessness associated with a threat, and perhaps on the perpetuation of dissociation as a secondary event. By definition, they also depend on the absence of a freeze discharge. As a result, we might expect to see a substantial difference in the pathological changes in the body, and therefore the diseases that occur in chronic stress, trauma, and traumatic stress.
The connection between sex hormones and histamine intolerance and MCAS. Right? So you might be wondering how sex hormones affect your body, how they affect mast cells. Well, if you stay with me, there's some pretty interesting things that I want to share with you. It turns out that your sex hormones affect mast cells in many, many different ways. And while it's true that more women seem to struggle with histamine intolerance than men, men who have hormone imbalances are also at great risk. All right, now if we take a look at this study here, this was a study that was done in an article, journal rather, of multidisciplinary respiratory medicine. And it was shown that fluctuations of estrogen trigger mast cells to degranulate, while testosterone and other androgens are credited to having a stabilizing effect. Progesterone has also been shown to have a stabilizing effect on mast cells. Now, let's break this up a little bit. What does this mean to you, right? And how does this apply to you? And how does this apply to your histamine and MCAS symptoms? Well, first thing, this study reminds us that estrogen triggers mast cells to break down, right? There's a big fancy medical term that's often thrown around. It's called degranulation, right? And so when mast cells break down or when they degranulate, they release histamine as well as a bunch of other chemical immune mediators, right? We also know from other studies that high levels of histamine stimulate estrogen. So what we have going on here is we have this vicious cycle, right, where we have this high estrogen causing mast cells to break apart and degranulate, releasing all this histamine, and we have histamine leading to more estrogen production. And so again, this is just one big nasty cycle. But to make matters worse, we also know that estrogen decreases DAO activity. And from previous videos, we talked about DAO being the enzyme that breaks down histamine, right? We talked about that in the video where we talked about mold, and we talked about that in the video where we talked about SIBO, some things related to gut health and histamine intolerance. But again, for those of you that are just joining us, again, DAO is this enzyme that breaks down histamine, right? There's two of them. There's DAO and HNMT. But if you're a woman, and let's say you have terrible menstrual cramps, or you have increased heart rate, you feel like your heart's racing, you have anxiety, maybe you have low blood pressure. Here again is why this is so important to you. The muscular layer of the uterus is loaded with H1 receptors. Now when estrogen or histamine bind to those H1 receptors, your uterus begins to contract. And one of the causes behind those painful cramps that you experience could be due to, number one, an excess of estrogen, which again, that estrogen blocks that DAO enzyme activity, which again causes excess histamine. And number two, estrogen causes mast cells to degranulate. And again, this again leads to more histamine release. So again, we have this vicious cycle that's going on. And this may explain, again, why you have some of those symptoms. So again, how does this tie into, again, some of the other symptoms that you might be experiencing? Well, H1 receptors are not only found in that muscular layer of the uterus, but it turns out that these H1 receptors are also found in the heart, they're found in the brain, they're found in the skin, they're found in the urinary tract, they're found in blood vessels, they're found in arteries, and they're found in capillaries. And is why you experience symptoms in so many different body parts. Now, the second thing that this study really points out is that sex hormones like testosterone and progesterone, these hormones actually have a stabilizing effect on mast cells. So again, if you're a man and you have low testosterone, or you're a man who has high estrogen, you are more prone to suffer with these symptoms of histamine intolerance and MCAS than a man who has healthy levels of testosterone and normal levels of estrogen. The second scenario applies to women who have low progesterone, right? Things like women during menopause or perimenopause. It might be a woman who has high estrogen from synthetic forms of birth control pills. So what can you start doing today if you suspect that hormone imbalances are filling up this histamine MCAS bucket, right? Well, number one, I want to share with you again 5 hormone lifestyle tips to help reduce this excess level of estrogen. So number one is exercise, right? This is so very important. By shedding extra pounds, you will actually reduce your estrogen load. And that's because estrogen is often stored in fat tissues. The more fat you have, the more estrogen dominant you become. The more estrogen you make, the more histamine you make, the more you block the DAO enzyme activity. So again, fat cells in the breast tissue, in the belly, in the back of the arms, these areas, these become reservoirs where your hormones can become problematic, right? This is where your androgens can actually get converted into estrogens. This is a process called aromatization. Right? Now, when your testosterone levels get converted into estrogen, this, of course, leaves you with low testosterone levels.
As the follicular cells develop, recall that they are going to release estrogen, and they will also release some progesterone. Now, most of the progesterone isn't really released until the formation of that corpus luteum. Okay. And we can follow that progression. If you can see, the amount of estrogen in our blood, okay, ovarian hormone levels, increases as those follicle cells develop, as the granulosa cells develop. And you can notice, if you will, my progesterone levels stay relatively low, and they really don't start climbing until the latter portion of development. So really not until we hit that tertiary follicle, really. And then they continue to climb as we get the corpus luteum formation, peaking during the formation of the mature corpus luteum, and then notice how it drops as that corpus luteum transitions into corpus albicans. Follow the estrogen all the way. Notice my estrogen is also going to peak, and that incidentally also corresponds with my LH surge. Okay, so we're going to get my LH surge right there. In addition to my estrogen peaking at that stage. And then after ovulation, estrogen drops. Now the mature corpus luteum will start to produce some estrogen in addition to the progesterone. And then that will decline as the corpus albicans is formed.
Stress under control, right? Stress hormones like cortisol have a profound impact, not only on histamine, but also on thyroid function, but also on your sex hormones. And again, in an upcoming video, I'll talk more about this connection between stress, cortisol, and histamine levels.